There's a clinical trial out of Oxford, published in 2010, that should have fundamentally changed senior medicine. But it didn't. The trial followed 271 patients with mild cognitive impairment, the early-stage memory loss that progresses to Alzheimer's disease in a significant percentage of cases. They gave half of them a specific vitamin protocol for 2 solid years. The other half received a placebo. The protocol was just 3 vitamins, B12, folate, and B6, taken daily for 2 years. The results, published in the journal PLOS ONE, were staggering. The patients on the vitamin protocol experienced a 53% reduction in the rate of brain atrophy on MRI compared to the placebo group. In the subset of patients who specifically had elevated homocysteine, the reduction was even larger. Furthermore, their cognitive scores held steady or actually improved over those 2 years, while the placebo group continued to decline. 53%. A 53% reduction in brain atrophy from 3 over-the-counter vitamins. This trial is real. The data is real. The biological mechanism is well understood. Yet almost no patient I've ever spoken with regarding memory concerns has ever heard of it. I'm Dr. Goodman, and on this channel, we explore the published research behind the medical decisions that matter most after age 65. Today, we are going to walk through what I now refer to as the cognitive protocol. 6 specific nutrients backed by strong individual research. We'll cover why this specific combination matters more than any single ingredient, the exact dose ranges used in the trials, the blood tests you should ask for before starting, and a realistic timeline for when you might actually see changes. Throughout this talk, I will reference patient cases. Names and details are illustrative composites drawn from common clinical patterns. Today's case is a man I'll call Walter. He is 71. 3 years before he came to see me, his wife started noticing small things. Walter would forget the names of common household objects mid-sentence. He would ask the same question twice in an hour. He would walk into a room and stand completely still, trying to remember why he came in. It's the kind of subtle decline that families tend to dismiss for the first 6 months, silently worry about for the next 6, and finally bring up to a doctor at month 18. His primary care physician did the standard workup, a short cognitive screen, and a basic blood panel. Nothing dramatic jumped out. The official diagnosis was mild cognitive impairment, age-related, prognosis uncertain. There was a soft, uncomfortable suggestion that the family might want to start preparing for what could come next. Walter's wife was not satisfied with that conversation. She did her own research, found the Oxford VITACOG trial, and brought it to me, along with a list of questions. What we did over the next 90 days became the exact protocol I am going to walk you through today. To understand why these 6 specific nutrients matter, you need to grasp a piece of brain biology that is rarely explained well in routine medicine. Your brain runs on a complex chemistry that heavily depends on a small number of critical nutrients. When any of them are insufficient, the chemistry slows down. When several are insufficient at the exact same time, that slowing becomes structural. The brain actually begins to physically shrink in specific regions, particularly the hippocampus and surrounding memory areas. This is known as age-related brain atrophy, and it accelerates aggressively after age 60 in patients whose nutrient status is suboptimal. The single most important contributor to this accelerated brain atrophy is something called elevated homocysteine. Homocysteine is an amino acid your body produces during normal metabolism. It is supposed to be quickly converted into other amino acids. However, that conversion process requires 3 nutrients to function properly: vitamin B12, folate, and vitamin B6. If any of those 3 are lacking, homocysteine accumulates in your blood. Elevated homocysteine is associated with vascular damage throughout the entire body, but the brain is incredibly sensitive to it. The small blood vessels feeding your memory centers begin to fail, inflammation rises, and atrophy accelerates. The Oxford VITACOG trial proved that providing those 3 B vitamins at therapeutic doses successfully lowered homocysteine and slowed brain atrophy by a clinically meaningful amount. Subsequent research expanded on this finding. A 2015 paper in the American Journal of Clinical Nutrition by Jernerén demonstrated that this B vitamin protocol worked dramatically better in patients who also had adequate omega-3 fatty acid levels. The two interventions are synergistic. The brain's repair pathway requires both the reduction of homocysteine and the building blocks provided by omega-3s at the exact same time. Two final pieces complete what I call the cognitive protocol. First is vitamin D, which has receptors throughout the brain and modulates both inflammation and neuroplasticity. Second is lion's mane, a medicinal mushroom shown in a 2009 phytotherapy research trial to produce measurable cognitive improvement in patients with mild cognitive impairment. 6 nutrients, each with solid individual research. The combination is what produces the real effect. When we ran Walter's lab work, it told a very clear story. His B12 was 295, technically within the normal range, but in older adults, levels under 450 are functionally low. His methylmalonic acid, a highly sensitive marker we discussed in a previous video, was elevated. His homocysteine was 16, well above the optimal target of under 9. His vitamin D was 22, which is considered insufficient, and his omega-3 index was estimated at just 3%, well below the protective range of above 6%. This profile is not unusual. In fact, it is the rule, not the exception, in older adults experiencing cognitive decline, whose primary care doctors have only checked basic standard labs. Before I walk through the protocol, I need to address the single most common mistake people make when adding multiple supplements. Do not buy everything at once and start taking it all on the same day. If you do that, it is impossible to know which supplement is helping, which isn't, and whether you are having a side effect from one specific component. The protocol I am about to detail should be added in stages, with testing at each stage, so you actually know what is working for your body. If you have ever taken any of these supplements individually for memory or cognitive concerns, please drop a comment letting me know what you noticed. The patterns I see in those responses directly help me build future videos. Here are the 6 components of the cognitive protocol, presented in the exact order I recommend adding them. Component 1 is vitamin B12 as methylcobalamin, which is the active form. The dose is 1,000 to 2,000 micrograms daily, taken sublingually, meaning dissolved under the tongue. Methylcobalamin is bioactive right out of the bottle. Cyanocobalamin, the cheap synthetic form found in most multivitamins, has to be converted by the body, and that conversion process is highly inefficient in older adults. Sublingual delivery is crucial because it bypasses the digestive absorption issues that affect so many older patients, especially those on metformin or proton pump inhibitors. The Oxford trial successfully used cyanocobalamin, but those patients had normal absorption. For the average older adult, sublingual methylcobalamin is far more reliable. Component 2 is folate as methylfolate. The dose is 400 to 800 micrograms daily. Again, methylfolate is the active form. Regular folic acid, the form found in fortified foods and cheap supplements, requires a bodily conversion that completely fails in roughly 40% of the population due to a common genetic variant called MTHFR. Methylfolate works regardless of your MTHFR status. This is critical because the patients who stand to benefit the most from folate supplementation are often the exact same patients who cannot convert cheap folic acid efficiently. Component 3 is vitamin B6 as P5P. The dose is 25 to 50 milligrams daily. P5P is pyridoxal 5-phosphate, the active form of B6. The principle is the same. Regular B6 or pyridoxine HCl requires conversion that becomes less efficient as we age. P5P works directly. A very important note here. Taking B6 above 100 milligrams daily can cause peripheral nerve damage. Stay under 50 milligrams for absolute safety. Component 4 is omega-3 DHA. The dose is 1,000 milligrams daily, ensuring that at least 700 milligrams is specifically DHA. DHA is the specific omega-3 that crosses the blood-brain barrier most readily and is physically incorporated into neural membranes. EPA, the other major omega-3, has great cardiovascular benefits but less direct cognitive benefit. Look for a high-quality fish oil or algae oil supplement with a very high DHA content. Remember, the Jernerén study showed the B vitamin effect was 3 times stronger in patients who had adequate omega-3 status. Component 5 is vitamin D3. The dose ranges from 2,000 to 4,000 international units daily, taken with a fat-containing meal to ensure absorption. The specific dose depends on your starting blood levels. Patients with severe deficiency under 20 nanograms per milliliter may need higher doses initially. Patients with adequate levels above 40 can use the lower end. This is one component where testing before and during supplementation is genuinely useful. Component 6 is lion's mane. The dose is 500 to 1,000 milligrams of fruiting body extract daily. The 2009 trial used 3 grams daily, but most modern extracts are highly concentrated, so the effective dose is lower. Lion's mane stimulates the production of nerve growth factor, which actively supports neural regeneration. In the published trial, the cognitive benefits showed up within 16 weeks of consistent use. 6 components. When combined, they directly address homocysteine elevation, omega-3 insufficiency, vitamin D modulation of inflammation, and direct neural growth factor stimulation. None of them work as fast as people hope. All of them work over months, not weeks. Walter's progression looked exactly like this. We added 1 new component every 2 weeks. He started with B12 alone for the first 2 weeks. We added folate at week 2, B6 at week 4, DHA at week 6, vitamin D at week 8, and lion's mane at week 10. By week 10, he was on the full protocol. We retested his lab markers at week 12. His 12-week labs were transformative. His homocysteine was down to 8 from 16. His B12 was over 600. His vitamin D was 38, up from 22. His omega-3 index was 6.1, up from 3. And his methylmalonic acid was completely back in the normal range. His symptoms actually started shifting around week 6, right after the DHA was added. His wife noticed it first. There were fewer mid-sentence stalls. His recall of names was sharper. Those moments of standing confused in a room became far less frequent. By week 12, the cognitive screen we ran in my office was meaningfully better than the one his primary care doctor had run 9 months prior. By week 24, his neurologist's standard mental status exam was back to the exact same level it had been 3 years earlier, right when his wife first noticed the changes. The progression Walter had been on appeared to be reversing, not just stopping, reversing. I need to issue 2 important warnings before I walk through the testing protocol. First, if you take warfarin or any vitamin K-sensitive blood thinner, the omega-3 component requires very close monitoring. High-dose fish oil can affect bleeding parameters. Talk to your physician before adding it. Second, if you take any glucose-lowering medication for diabetes, the protocol itself does not directly affect blood sugar, but the lifestyle changes you might make alongside it, like a better diet, improved sleep, or more movement, often do. Monitor your numbers closely during the first 3 months and adjust your medications with your prescribing physician as needed. Step 1. Get the right testing first. Ask explicitly for serum B12, methylmalonic acid, homocysteine, 25-hydroxyvitamin D, and an omega-3 index test. The omega-3 index isn't routinely run in most primary care offices, but it is available through Quest Diagnostics, LabCorp, and various direct-to-consumer testing services. The total cost for this panel is typically under $300. Step 2. Establish baselines for your symptoms. Have a family member document specific, dated examples of memory or cognitive concerns over a 2-week period. Quantify what you can. This becomes your reference point. Without it, you cannot accurately assess change because cognitive recovery is almost always noticed first by family members rather than the patient themselves. Step 3. Add the components in stages, spacing them 2 weeks apart. This allows you to easily identify any component that might not agree with your stomach. Most people tolerate all 6 components without any issue, but staggered introduction is simply the safer, smarter approach. Step 4. Retest at 3 months. You want to see your homocysteine under 9. B12 should be over 500. Vitamin D should be sitting between 30 and 50. The omega-3 index should be over 6. If any of these numbers aren't moving, the dose might need adjustment, or there may be an underlying absorption issue worth investigating. Step 5. Reassess cognitive function at 6 months with formal testing. The Montreal Cognitive Assessment, known as the MoCA, is freely available and takes about 10 minutes to administer. Many physicians will gladly run it during a routine appointment if you ask. Compare that score to the baseline established before you started the protocol. So, what can you realistically expect? For mild cognitive impairment caught early, particularly in patients who have elevated homocysteine and suboptimal nutrient status, the Oxford trial data suggests that roughly half will see meaningful slowing or actual reversal. About a quarter will see partial benefit, and about a quarter may see no change at all. For more advanced cognitive decline, including a formal diagnosis of Alzheimer's disease, the protocol may slow the progression, but it is unlikely to produce the kind of dramatic reversal Walter experienced. The trial data on advanced disease is much more modest. For patients with normal cognition who simply want to use the protocol preventatively, the long-term observational data is favorable but harder to interpret definitively. Lower homocysteine, adequate vitamin D, sufficient omega-3s, and regular B vitamin intake are all individually associated with a significantly reduced risk of dementia in large cohort studies. Walter sent me a video at his 18-month mark. He was sitting in a chair reading a book to his granddaughter. It was the exact same chair, the same lamp, and the same posture as a video his wife had taken 3 years earlier, when the decline was just starting, and they were both pretending it wasn't happening. The difference between the 2 videos was the eye contact, the sharp engagement with the child, and the effortless tracking of the conversation when his granddaughter asked a question. His wife wrote to me afterward. She said the day she realized he was truly reversing was the day he asked her, completely unprompted, about an old friend whose name he had forgotten for over a year. He remembered it. The forgetting had not been permanent. Cognitive decline after age 60 is one of the conditions families fear the absolute most. It is the one condition most patients believe is completely unstoppable. The clinical trial data tells a much more hopeful story for a meaningful subset of those patients. The protocol is straightforward, the cost is modest, the testing is accessible, and the timeline is measured in months, not years. If someone you love is in the early stages of memory concern, this is the exact conversation worth having with their physician. Print out the VITACOG study, show them this video, ask for the testing panel. The absolute worst-case scenario is that you have ruled out one preventable cause. The best-case scenario is the exact case Walter's wife described. Your father remembers a friend's name entirely on his own, 18 months after you both had quietly accepted that he might never be able to do that again. Please drop a comment and let me know if this video reaches someone in your family who really needs to hear it. The patterns of who shares these videos and why deeply shape the content I make next. I'm Dr. Goodman. Take care of each other.